This is a radiosurgery for a urogenital prolaps after failure of vaginal approach. The plan for this patient is laparoscopic pectopexy. So we began as usual our surgery by cutting and sealing the left round ligament, and we will try to identify both pectineal ligament, which are just below the external iliac vein. And when you open the retroperitoneal element, you can reach clearly the pectineal ligament. We will do the same procedure on the right side, and we will seal and cut the right round ligament, and we will try to identify the pectineal ligament. So we will pull in the fatty tissue just below the external iliac vein that allows us to reach the pectineal ligament quickly. You can see, if you have the knowledge for a pelvic lymphadenectomy, reaching the pectineal ligament is very quick. Let's go now to do the vesicovaginal dissection, and this dissection is quite challenging due to the previous vaginal surgery. You can see we cut the vesicovaginal peritoneum till we reach the left round ligament, and we will do the same steps on the right side. Let's go now to do the vesicovaginal dissection, and for that we have to seal and cut both bladder pillars. That allows us to pull down the bladder. And as you see, this dissection is quite difficult due to the previous vaginal surgery. So the dissection is more difficult than usual. And for that, if you want to do a good dissection, go laterally. And after, you can remove all the connective tissue between the bladder and between the vagina. The goal of the vesicovaginal dissection is to reach the trigone area, because more you are lateral and more you are deep, more your functional and anatomical outcome will be better. You can see the dissection is more difficult than usually, but when you follow the bubble, you can see clearly the vagina and the trigone area. Let's put now a sponge between the bladder and between the vagina, and we can pull down this sponge that allows us to win 4 and 5 millimeter. It's a postmenopausal patient, and in this kind of patient we have the use to do a subtotal hysterectomy with bilateral lymphadenectomy. And as you see, we seal and cut the IP ligament, the left one, and we seal and cut in the same maneuver the IP ligament, the right one. Let's go now control the right uterine pedicle with the Ligashow 5 mm sealing device, and we seal and cut both uterine pedicle, the right one, and now you can see we control the left one. Now the uterus should be well devascularized, and we can do a subtotal hysterectomy with a monopolar needle in a section current. For that, you have to remove the uterine manipulator to have a better access on the cervical area. It's time to close the remnant cervix with Vibrine 1 stitch that allows us to close the endocervical canal and with this maneuver, we decrease the risk of vaginal ascending infection, and we can do, as you see, a sacrocolpopexy that allows us to have a better view of posterior compartment. And as you see, it's a severe prolaps, so it's mandatory to do the rectovaginal dissection till we reach the anal canal to correct the rectal prolaps associated in this patient. It's really important as well to do the dissection between the rectum and the vagina in exactly the middle of the space, and you can see the rectum downward, you see the vagina with huge vena, and it's not mandatory to go till we reach levator animal like we do in sacrocolpopexy. So let's place our shaped crossed mesh, and we fix the mesh with absorbable vicryl tacker in the posterior aspect of the vagina, and this procedure decreases the risk of vaginal mesh erosion, and that can be found sometime with the stitches. These stitches disappear after 2 months. Now we will do a fixation of the anterior mesh, and as you see, we fix the mesh on the anterior aspect of the vagina till we reach the trigone area. It's really important to place the mesh as deep as possible for a better prolapse correction. So it's a classical pectopexy, as you see, but due to the volume of the prolapse, we see that if we try to fix the arms of our meshes on the pectineal ligament, the prolapse will not be completely reduced. So we decide at this moment to change the technique, because if you do a pectopexy with a very long and very huge vagina, the anatomical result will be not good as desired. So after the complete treatment of the anterior and posterior compartment, we decide to switch to another technique. You can see if we try to place both lateral arms on the pectineal ligament, the prolapse will not be completely reduced, and we decided to fix the cervix on the promontory for a better tension and for a better prolapse reduction. You can see, so we decided to open the peritoneum just above the sacral promontory, and we can use as well the bipolar or the ligature, and we will try to reach the vertebral common anterior ligament. It's important at this level not to damage the right hypogastric nerve. As you see, we use now a Etipon non-absorbable stitch with a taper cut needle, and we will paste 2 times inside the vertebral anterior common ligament, and we will fix directly the cervix on the promontory. But we have to remove both lateral arms that normally we'll use for pectopexy, and as you see, we will paste the stitch through the cervix and through the mesh for a complete cervical Fixation. The stitch is 80-1, and as you see, the stitch is paid through the mesh and through the cervix. And now we can fix directly the cervix on the sacral promontory, and the anatomical result will be perfect, and we will see the result at the end of the video. Now let's remove the stitch that was used for a bladder fixation, and we will use the bladder peritoneum for covering the mesh, because it's mandatory to cover the mesh to decrease the risk of postoperative bowel adhesion or bowel occlusion. Let's now morcellate the uterus and clean the pelvis. In conclusion, if you planned a pectopexy and there is no perfect anatomical result, switch to a sacrocolpopexy for a better outcome. You can see now our anatomical result, a post-operative anatomical result, which is completely perfect. Thank you for your attention, and see you for my next video.